Let's talk about cardiac cath. What is a cardiac cath? Oh yeah, we're gonna go in there and dig around and look at your heart vessels, right? Because I need to see what I need to do inside of there. Like what? What are my options once I get in there? You could do a stent, a balloon. Oh my God, y'all are so smart. Yeah, what else could you do? Or you could go in there and be like, not today, Satan. Ain't nothing gonna happen, and I need to come out, and we're gonna schedule a cabbage. We're gonna schedule a cabbage because I can't get up in there. Yeah. Okay. You will also see this called a coronary angiography. Because coronary stands for heart, angio, vesselography. So we're going to take a picture of the through contrast. Okay. What's an angiogram? Angio means vessel. Gram means picture. So we're going to take a picture of the vessels. You may see it called a coronary angioplasty. Okay. Coronary means heart, angio, vessel, plasty. We dug around in there. Okay. So that means like we actually did something. We did a stent or we did a balloon or something. Okay. You're the nurse before cardiac cath. Patient comes to you. You want them NPO for at least 6 to 8 hours. What if they're like, well, I just had chest pain after I ate Thai food? Okay. Well, then we will pray. Let us pray. Okay. Your number one job, the first thing you should do is ask if they are allergic to shellfish or iodine. How come? You're about to give contrast, right? If they don't have a Foley already, we're going to put one in, right? I need to know what their cardiac output is because I'm digging around and I mean their urinary output because I'm digging around on their heart. Yes. All right. Assess for a groin rash. Why am I looking at their groin? You're going to go through the femoral artery. What am I looking for? Like a syphilis rash, a herpes, it could be a yeast rash. Now, why would I be like, oh no? Because I'm about to feed something all the way into their heart. Do you think we want to give them herpes of the heart? No, no. All right, you have to make sure that that there is a consent form signed. Be real careful how they word this on an exam because it's not your job to get the consent form signed, right? But you can witness and you can make sure that there is one in the chart that is already signed. Okay, we are going to do a chest x-ray first because I need to see what I'm digging around in. Yes? Okay. Make sure you have 2 large bore IVs because what are your risks in cardiac cath? Bleeding. And I'm digging around in their heart. It's probably going to irritate it. So dysrhythmias or death. I think that's where you're going. Okay. So dysrhythmias, bleeding, right? Because patient, you need to lay still. They don't knock you out for this, right? We're just like, could you be still while we dig in your coronary arteries? Oh my God, what if you have to sneeze or something? I always panic about something like that. Okay. Another big job of yours, assess pulses, document the strength, and you mark the pulses with a Sharpie. Why am I doing that? You need to know where they are, but why am I marking them with a Sharpie? Hello. Hi. She's like, so you do. Yeah. Okay, you're going through the femoral artery, right? So afterwards, isn't it possible you could have damaged the artery in some kind of way and then your whole entire freaking leg doesn't get blood flow? So one of the biggest things you do post cardiac cath is you have to assess their pulses every 15 minutes because if all of a sudden they don't have one in that leg that you did it and somebody done messed up and they're going to lose their leg, right? But these are patients that already usually, have heart issues. So isn't it possible that they could already have +1 pulses, right? Like if they have peripheral artery disease or something. So wouldn't I want to know that? Because what happens if I'm the post cardiac cath nurse and you didn't write what her pulses were first, and all of a sudden I see, oh my gosh, she has +1 pulses. You're going to freak out, but then come to find out, it was always this way. Yes. Okay. So it is very important that you assess the pulses, document their strength, and then write down +1, +2, +3, +4, whatever it is, and then mark them with a Sharpie so that somebody can find them afterwards. Okay. Like literally on their skin. Yes. Like this. Just like they do before surgery. Don't take this leg, take this leg, right? Like we underestimate the errors of the medical field. All right. So make sure that you've had a BUN and creatinine, right? Why am I doing a BUN and creatinine in this case? They're about to get contrast, right? Okay. We need a type and cross just in case somebody does sneeze while they're up in there, right? Okay. And then we need a full coags panel because I'm about to start them on heparin and Coumadin after cardiac cath. Do not give them anti-coags before you go into cardiac cath, right? Okay. All right. EKG telemetry. So I'm gonna put them on leads because I kind of need to watch what their heart's doing while I'm digging in it. Cool. We do conscious sedation. So we're like, here's some Ativan or something. Have a good cardiac cath. Okay. We will give them antiplatelet therapy because the likelihood of platelets gathering and causing a secondary clot is high. Okay. What are some antiplatelet drugs that I could give? Okay. Aspirin's good. Okay. Yeah. What's the other big one? Big antiplatelet aggregate that we give all the people. That is a blood thinner. That is an anticoag. Okay. All right, come on, everyone. Yeah, you haven't studied pharm at all. So, oh, that is. It's clopidogrel. Okay. The answer is clopidogrel. All right. All right. And then we want to, if it is a elective cardiac cath, we would like them to hold their coags for 1 to 2 days before. But if they're in an acute chest pain situation, of course. Now, remember, I told y'all to look for that word elective, right? Mm-hmm. If you see the word elective, that usually means they want you to hold it for some reason. Okay. You're going to hold metformin on the day of the procedure. Why am I doing that? Y'all know the answer to this. I know you know the answer to this because I've heard you say it 120 times. Uh-huh. And when you're giving contrast to a patient, you have to hold metformin on that day and the day afterwards. And what do you give them in the meantime? Sliding scale insulin, because metformin and contrast both compete for kidney excretion. I know y'all knew that, right? Or is this new information to you? Okay, okay. Because I was like, I feel like we've done this like lots of times. Okay. Adjust their insulin, or you may have to add it if needed, because obviously their body's like, something is wrong. They're going to be producing a lot of cortisol, which is going to do what to their blood sugar? Increase it. All right. We're going to give them an IV fluid bolus. Why am I doing that? Right before cardiac cath, we give them a bolus. I need those vessels plump so I don't poke something, right? Okay. Then we're going to do a timeout. We're going to be like, hello, everyone. We have gathered here today for a cardiac cath, right? Y'all know what a timeout is. Okay. You will use electric clippers to shave the site, okay? If you have a very hairy groin, we need to clip that because I don't want to put your pubes up into the heart. Okay. So, and then you need to use a chlorine-based prep to clean like chlorhexidine, okay? But don't shave it because if you try to shave it and then you use chlorhexidine, that's going to burn. It's going to cause a rash, okay? What's the best way to prevent an infection in a patient with cardiac cath? All right, hand washing. Good, good. And then you already need to tell the patient what to expect when they come out of cardiac cath because the first 4 hours after cardiac cath are yucky, okay? Get a set of vitals so we can make sure we're stable before we go into cardiac cath. They go into cardiac cath. Now, it is expected during cardiac cath for them to have some dysrhythmias. Now, I mean, not VFib or something. That's bad. You know, but as you're digging through the heart may be like, I'm angry, you know. And it's just something that you watch. Okay. But once they take out the tube, they shouldn't be so angry. Now, you're going to be a separate nurse coming for a patient after cardiac cath. The patient needs to be laying completely flat with their head just on a teeny tiny little crappy hospital pillow. Okay. And their leg needs to be straight and flat for at least 4 hours. Okay. And that's because the site that you went in is on the panty line, right? The femoral artery is where your panty line is. So if they bend their leg, they're bending where that site was and they could bleed. You understand? Cool. So your job is to check vitals every 15 minutes for 2 hours because what am I looking for? We're looking for bleeding. And how would I know they're bleeding through their vitals? BP is going to tank. Heart rate's going to, right, it's going to increase. Okay. So after 24 hours post cardiac cath, we will start them on oral anticoags. Okay. Now they're already going to be started on heparin. That's IV. But then we're going to start them on oral warfarin. Why am I doing both? Warfarin takes longer to kick in. Heparin is IV, so it is very quick. What are the labs that I do for heparin? APTT. What's a normal APTT? Normal. Third, that is not normal. Okay, that's fine. Somewhere between 30 to 45 is usually where it's at. Okay, so an APTT, though, we want them to be therapeutic, right? So we want them to be like between 45 to 80 is where we want them on heparin. What's our red flag APTT? At 90, we have to do something. I need to assess the patient for bleeding, let the doctor know. We may need to administer the antidote at that time, which is, what's the antidote for heparin? Protamine sulfate. Ma'am, I don't know what's happening to you. Okay. Okay. Protamine sulfate. Yes. Okay. What are the labs that we do for warfarin? Excuse me? No, I didn't hear what you said. You may have been correct. Try it again. I won't be mad. Yes, it is a PT and an INR. How do y'all not know these? Y'all are not studying at all, and I am very concerned for farm. All right, PT. What's a normal PT? 11 to 13, because remember how old is a preteen? But we want it to be therapeutic, which is usually around at least 2 times the normal. So they're going to be around 26 to 30 something, okay? What is a normal INR? 1. A normal INR is 1. What is a therapeutic INR if they're on warfarin? 2 to 3. What is our red flag INR if they're on warfarin? 5. Okay, that's when we have to do something, okay? All right, so we're going to start them on anticoags, and then you need to assess the 6 Ps on the leg that they went into the femoral artery, okay? What happens if I see a 6P on that leg? You need to notify the provider immediately, because what does that tell me? They done messed up the femoral artery, and they're not getting blood flow to the bottom of their leg. What happens if I don't report it immediately? They will lose their leg. Are we clear? All right. We're going to continue to hold the metformin for 48 hours, right? And we need to give insulin in the meantime so they can get rid of all that contrast, which means I need to give a lot of IV fluids. Flush all that out, right? Okay. They can eat after the procedure. Watch their blood pressure and heart rate for bleeding. Watch their injection site, and you have to monitor it and document it at least every 30 minutes. What happens if I pull back the sheet and it's from the site? Put pressure 1 inch above the insertion site, and then help. Yeah, because you're going to need some help. Okay. If the patient complains of back pain, remember back pain? Bad, right? Back pain is always bad. What does that mean? They're bleeding. That is a retroperitoneal hematoma. So if they say they have severe abdominal pain, or if they can complain of groin pain or back pain, then that means because they're laying flat, that blood is now draining to the back. Okay. So that's a big red flag. We're going to have them on EKG telemetry for a long time, right? Watch the neuro status, because I want to make sure if they're bleeding, you're going to start to see neuro changes. Yes. Okay. After 24 hours, you can take the dressing off the femoral artery site, but it's meant to be put on there as like a pressure dressing. So don't mess with it. Okay. And then initiate heparin if it's ordered at that time. So what are the complications from cardiac cath? When do we panic? If they're spurting from the site. That's not good. Okay. That's not good. If they have the 6 Ps, what does that tell me? You're about to get a cold dead leg. I need to report that immediately. The patient has back pain, abdominal pain, or groin pain. Report that immediately, because they've got a hematoma. The hematoma is a collection of blood, and it's retroperitoneal. What does retro mean? Behind the peritoneum, right? So it's going to be putting pressure. They can also get arrhythmias after cardiac cath. Now, that is not normal, and I would report that. Do you understand? If it's new onset. If they had AFib going into the cardiac cath, they have AFib out of the cardiac cath, well, no harm, no foul, okay? But if all of a sudden they have an arrhythmia they didn't have before, I need to report that. Do you understand cardiac cath?